Good morning. My name is Andrew Grubric, and I'm an advanced laparoscopic and endoscopic surgeon here at the Cleveland Clinic. I specialize in functional disease of the upper GI tract. It's quite the honor to be able to speak to you all at the MIND 2025 EDS Mini Symposium here at MUSC. I apologize that I can't be here in person today. However, I wanted to be able to share my experience regarding the use of gastric per-oral endoscopic myotomy or the GPOEM procedure for Ehlers-Danlos related gastroparesis. Here are my disclosures. The objectives of this talk will center around understanding the context of gastroparesis within the EDS population, establish the technical basics of the GPOEM procedure, and identify potential candidates for GPOEM within the multidisciplinary EDS framework. Based on a 2015 study from Mayo Clinic, over half of patients with EDS, particularly the hypermobility subtype, will exhibit significant GI symptoms. Of these patients, 12% were found to have gastroparesis. Additionally, 28.3% and 60% of patients were also found to have lower GI issues, including colonic dysmotility and dyssynergia, respectively. This will be important for later in the discussion. Gastroparesis is a motility disorder of the stomach, defined by delayed gastric emptying in the absence of mechanical obstruction. Classically, there are three subtypes, including post-surgical, which is typically resultant from vagal nerve trauma following procedures like hiatal hernia repair, fundoplication, Heller myotomy, lung transplantation, or cardiac ablation. Diabetic is traditionally taught in medical training as a well-established complication of poor glycemic control. Idiopathic has long been used as a rather lazy catch-all for a myriad of more occult gastroparesis etiologies, including autoimmune, post-viral, neuromuscular, medication-related, and connective tissue disease like EDS. The primary physiologic function of the stomach is to serve as a food reservoir for bolus eating and to provide mechanical, enzymatic, and acid-mediated digestion of food. This process begins with fundic accommodation of the initial food bolus. Food then traverses into the body of the stomach and subsequently into the antrum, where cycled contractions churn and break down the food into a slurry, which will eventually pass through a relaxed pylorus. Coordination of antral and duodenal contractions is also key for antegrade flow. Patients with gastroparesis may exhibit one or multiple dysfunctions in any of these processes. Furthermore, upwards of 1/3 of gastroparesis patients will exhibit concomitant colonic and/or small bowel dysmotility. Gastric per-oral endoscopic myotomy is a pyloric widening or drainage procedure which is based on the principles of surgical pyloroplasty and pyloromyotomy. GPOEM utilizes third-space endoscopic techniques originally used for esophageal POEM and endoscopic submucosal dissection for early-stage GI malignancy. The GPOEM procedure was first developed by Kashab and colleagues at Johns Hopkins in 2013, utilizing a greater curvature approach. In 2016, Drs. Ponsky and Crow here at the Cleveland Clinic modified the procedure to a lesser curvature approach, which significantly decreased procedural time. Several studies, including a 2020 meta-analysis by Mohan and colleagues, demonstrated similar efficacy in comparison to pyloroplasty for decreasing gastroparesis-related symptoms. Importantly, GPOEM tended to have less pain, recovery time, complications, and hospital length of stay. Here at Cleveland Clinic, we also found a 26% lower procedural cost in comparison to a pyloroplasty. Here you can see a graphical and corresponding endoscopic depiction of the GPOEM procedure. The endoscope is prepared with a clear cap, which provides tissue retraction. An appropriate area, 3 to 4 centimeters proximal to the pylorus on the lesser curvature of the stomach, is identified and injected with a mixture of saline and methylene blue to separate the mucosa from the underlying muscle. On the apex of this bleb, a 2 centimeter transverse incision is made with TT knife electrocautery to access the submucosal space. The submucosal tunnel is dissected distally to expose the pylorus, depicted here in the bottom third image. The pylorus is then systematically divided, effectively breaking the ring, until the submucosa on the duodenal side and the gastric serosa at the 12 o'clock position is visualized, here in the fourth image. The mucosal incision is then closed with 4 or 5 endoscopic clips. Think of these as sutures. And then finally, the finished product is a teardrop-shaped pylorus, typically 3 to 4 times larger than the original pyloric opening. Here at Cleveland Clinic, patients follow a strict protocol for the GPOEM, which begins during the multidisciplinary outpatient consultation with gastroenterology and surgery. We aim to optimize their bowel function if needed, with a goal for at least 3 bowel movement days per week. GPOEM here is a same-day surgery, outpatient, and is performed under general anesthesia. Prior to the procedure, patients are placed on a liquid diet for 3 days, including clear liquids the day prior for complete gastric clearance. Postoperatively, patients are maintained on a full liquid diet for at least 7 to 10 days. While there has always been some concern for knocking off the clips, the main reason for this liquid diet is that approximately half of patients experience worsening symptoms in the early postoperative course. During this phase, we lean heavily on metoclopramide, erythromycin, and antiemetics in patients who are able to take them. While the procedure is not typically considered painful, some patients experience burning and pressure sensations in the epigastric region, which are best treated with Tylenol and over-the-counter antacid. NSAIDs are held for 2 weeks due to risk of ulceration. To offset the risk of ulceration and delayed perforation, patients are placed on high-intensity proton pump inhibitor and Carafate both twice daily for 30 days. We counsel patients that the full effects of the procedure are typically seen in 6 to 12 weeks after the procedure. This is clinical data from our most recent GPOEM study of 115 patients showing the various clinical success rates between the gastroparesis subtypes. Clinical response was based on significant reduction in postoperative gastroparesis cardinal symptom index score in comparison to the patient's preoperative score. Due to the heterogeneity in how this retrospective data was originally recorded and subsequently collected, only one single EDS gastroparesis patient was actually captured. From my personal experience treating many of the patients included in this study, there were actually 30 plus patients with suspected EDS between the idiopathic and post-viral cohorts as well. The single EDS gastroparesis patient here highlighted in red had a clinically significant reduction in symptoms. The idiopathic and post-viral, shown here in green and blue respectively, showed 58.9% and 66.7% response rates. The response rates in these patients are considerably lower in comparison to other gastroparesis subtypes like the diabetic and post-surgical groups, however, are comparable to other studies. This data was recently presented at American College of Gastroenterology 2024 as part of our study using a novel technology known as electrogastrography, or EGG, to assess that the gastric myoelectrical activity patterns were predictive of response to GPOEM. The EGG test involves consumption of a water load over 5 minutes and using transcutaneous abdominal pads to measure gastric electrical activity over 30 minutes, similar to a cardiac EKG. Unfortunately, we did not find that any electrical pattern was predictive of GPOEM success. What we did find, however, is that patients with poor water load tolerance, less than 300 milliliters, as well as reduced clinical nausea and vomiting scores, were associated with GPOEM failure. Regrettably, we're still in search of objective and reproducible ways to better characterize and phenotype gastroparesis patients. Always Sunny in Philadelphia has long been one of my favorite TV shows. When I was first out in practice, I often felt like Charlie Day here when seeing these patients in my clinic. Their diagnosis, medications, and allergies can be absolutely overwhelming and intimidating at times. Can you even help this patient? Is GPOEM right for them? And where do you even start? You focus on the symptoms. Based on all the available literature, society guidelines, and our own clinical experience, a thorough history and physical is the most straightforward, reproducible, and cost-effective way to determine if a patient has a reasonable chance of improvements with GPOEM. Most of this is simply what you would expect from a medical student studying for the Step 2 CK exam. Chief complaints, associated symptoms, exacerbating and remitting factors, and some other pointed questions. I always ask every single patient, what are the top 3 GI symptoms that most affect your quality of life? This really gives a good foundation on how to guide the discussion. I want to know the when, the why, and the how much. This clues me in to whether this patient has a primary gastric problem or may have some other concomitant dysmotility requiring further workup and optimization. Additionally, we calculate a GCSI, or gastroparesis cardinal symptom index score, which I referenced earlier, which helps to quantify their symptoms. So how is this information relevant? I generated this sort of traffic light table breaking down various clinical symptoms and markers to determine GPOEM candidacy. For GPOEM success, we're looking for patients that are in the moderate to severe range on their GCSI score. Patients with mild symptoms less than 1.9 probably will not dramatically benefit from the procedure. And patients with very severe scores, 4.5 or greater, typically have complex conditions which require a more total gut and GI psych workup. Nausea is always challenging, but patients that primarily exhibit postprandial nausea are far more likely to benefit than patients with constant 24/7 nausea. Vomiting is key, as this is the #1 symptom which improves after GPOEM. I'm always hesitant in patients who do not vomit, but it's important to keep in mind that some patients who may previously have vomited utilize dietary and pharmacologic strategies to avoid emesis. With satiety and fullness, patients that can only tolerate a few bites of food likely exhibit gastric accommodation dysfunction, which is unlikely to respond to GPOEM. Alternatively, patients with delayed fullness skipping meals are far more likely to improve. Abdominal pain rarely improves after GPOEM. However, patients with postprandial pressure in the epigastric region may see some benefits. Central or lower abdominal cramping and bloating pains are almost certainly associated with colonic and/or small bowel issues. With dietary tolerance, we're looking mainly for patients that are tolerating soft foods or modest amounts of liquids. Think back to our water load satiety finding from the EGG study. Patients who cannot tolerate liquids or who actually are eating completely regular diets are likely non-responders. I wanted to highlight bowel function here, as this is a major component to our candidacy. It is critical that patients are moving their bowels at least 3 days out of the week. This is mainly to exclude any aspect of gastrocolic reflex dysfunction and to ensure what goes in must come out. Patients with severe constipation almost never respond, and some may even experience worse nausea and bloating symptoms after GPOEM by effectively shunting increased gastric flow into a more dysfunctional lower GI tract. Our gastroenterologists are often able to shunt patients into GPOEM candidacy with proper medical management of their lower GI issues using medications like Motegrity, Trulance, and Ibsrela. Weight trajectory is important mainly because some patients may be too malnourished and require feeding access for stabilization. Obesity is not uncommon with gastroparesis in 2025, mainly because these patients adapt to consumption of simple carbohydrates and sugars and live sedentary lifestyles. I'm always extremely hesitant if a patient is eating solid foods and gaining considerable weight. Tolerance of jejunal tube feeds is a nice bonus because for patients who tolerate these feeds, it's reasonable to conclude that they have a primary gastric dysfunction. I wanted to share this study because it highlights the importance of constipation management preoperatively when considering GPOEM. This study, published last year out of Belgium, demonstrated that the success rate of GPOEM was essentially cut in half in patients with significant constipation in comparison to those patients with appropriate bowel function. With all of this information in aggregate, I wanted to at least portray the ideal GPOEM candidate. This would be a patient who exhibits primary symptoms of vomiting as well as postprandial fullness and nausea. They have limited or minor symptoms of abdominal pain and bloating. They're tolerating at least a full liquid diet and able to consume at least 10 ounces of water in under 5 minutes. They're maintaining weight or exhibiting some minor weight loss. Most importantly, they're having reasonable bowel function. Patients who are on chronic opioids, GLP-1 medications, or 3 or more antipsychotic medications have a much higher risk of failure, primarily due to the motility effects of these drugs. Lastly, I wanted to touch on the importance of multidisciplinary care for these patients. Here at Cleveland Clinic, I'm extraordinarily thankful for the support that we receive from gastroenterology, nutrition, and GI psychology. With their assistance, we can often take patients who may be marginal GPOEM candidates and turn them into gastroparesis success stories. I often tell patients that care is like a roof on a house supported by the 4 columns depicted here. If you take away 1 column, the roof may sag. If you take away 2 columns, the roof will be structurally unsound. If you take away 3, it's guaranteed to collapse. It all adds up. In summary, care for EDS patients with gastroparesis can be quite challenging. Some may be candidates for GPOEM while others may not. Take a comprehensive history and focus on their symptoms, particularly around nausea and vomiting, dietary tolerance, and bowel function. Always consider and treat concomitant dysmotility in the small bowel, colon, and pelvic floor. Some patients with concomitant dysmotility may develop candidacy if they are properly optimized. And remember, it's a team sport. I sincerely thank Dr. Aaron Leshner for reaching out to me many months ago, and for Dr. Rowland for granting me the opportunity to speak to you all today. This is certainly a topic that is near and dear to my heart, and please do not hesitate to reach out with any questions or collaborations. Thank you.